Hi, everyone, and welcome to our MPYA webinar today. I'm excited that you're all joining in, and I'm sure that more people will join in. I would ask Lindsay to please introduce the panelists and give us guidance on who's speaking this afternoon. Thank you.
Hi, everyone. This is Lindsay Garrison speaking. I'm the program manager for the MPYA Study. Perhaps Jessica could introduce. I have my screen shared and can't actually see anyone else on the chat anymore.
Thanks, Lindsay, and thanks, Dr. Murugi, for the opportunity to be here today. I'm actually going to turn the presentation over to Dr. Elizabeth Bakusi, who will welcome all of the members of this webinar and introduce us to the presentation today. Dr. Bakusi, please.
Thank you. Good afternoon, everybody. I hope you can see me. It's such a pleasure to be here with you this afternoon, and thank you very much for making time to be able to come and hear the story that we hope to be able to share with you. Just very briefly, this is a study that the principal investigators, I had the privilege of being part of the team, Dr. Nelly Mugo, who I hope will join us, and Jessica Habara. And we have some of our co-investigators who are here with us today, Professor Kenneth Ngure, Catherine Kiptines, Kevin Kamolo, Eric Seda, and you'll be hopefully getting to hear from some of them. Next slide, please. So we want to give you a study overview, and we hope after that we'll talk about the impact of short message reminders on PrEP adherence, talk about factors that influence PrEP adherence and the reasons why others declined PrEP, talk about PrEP formulation practices, talk about the acceptability of the Wisepill, give a summary, and we hope we'll have a few minutes at the end to just have an open discussion. Just as a reminder, we know that young women in sub-Saharan Africa, they really are a top priority for PrEP rollout because as many as 7,000 new infections occur every week in this population. The challenge has been adherence for these young women, and we need to find new ways to be able to measure and support them when they start PrEP to be able to be adherent on it. We need to understand if they're taking PrEP when they need it. This is called prevention effective adherence. So the aims of this study, as indicated here, was really using the next generation Wisepill device in a cohort of about 350 young HIV uninfected Kenyan women who are initiating PrEP so that we could measure real-time adherence, determine the impact of sending them SMSs, messages on adherence, determine the technical function, acceptability, the cost, the validity of the next generation Wisepill device coupled with SMS reminders, and also use the Wisepill adherence data and multiple assessments of HIV risk behavior and perceptions to measure their prevention effective adherence. So these were young women who are at risk, high risk of acquiring HIV. They were aged between 18 to 24. They were in Kisumu and in Thika. We recruited them from colleges, vocational institutes, informal settlements, and community-based organizations, including those who could have been engaged in sex work. Their voice risk scores suggested a high risk, that is 5+, and that based on their age, they're being single, having a sexual partner who possibly had other sexual partners, and their alcohol use or being in a sero-different couple. It was clinically safe for these young women to take PrEP. They were sexually active, and they needed to also have a cellular phone. So, and I've seen my colleague, Dr. Nelly has joined. Welcome, Nelly. We randomized them. This is a randomized controlled trial of SMS reminders. SMSs were sent daily to half the women, and this could be sent only for missed or delayed doses, and participants chose the kind of message that would be sent to them for confidentiality. All these women were offered PrEP, and they were encouraged to take it for at least 6 months with quarterly refills given if PrEP still felt good, like a good HIV prevention option for them. We had a robust assessment of their social behavioral data. We collected quarterly visits over the 2 years when they were in the study, and we had weekly SMS surveys from 6 to 24 months. Serially, we had qualitative interviews that were done among 50 of the participants within this cohort. I over to my colleague after this. And for adherence, just as I hand it over, talking about, we measured it with the Wisepill device. You can see this. Every opening is marked with a date and timestamp as a proxy for pill ingestion. So the assumption is when they open it up, they will be actually taking the pills. And then there were pharmacy refills that we also used to be able to measure adherence. And we did blood tests quarterly for PrEP drug levels as a very objective marker of adherence. This was limited to just 15% of the total cohort just because of the cost of doing these tests. So I will hand it over here to our next panelist, who will pick it from here and take it forward.
Thank you, Dr. Bukusi. So I will talk about the impact of SMS reminders on PrEP adherence. So a quick overview on PrEP adherence. Among 348 participants, retention was high. It was 82% at 24 months. Wisepill data was available for 88% of the study follow-up period. In addition, overall Wisepill adherence was 27% among participants picking up PrEP over the full 2-year study period. And we had a total of 4 participants, all in Kisumu, who acquired HIV during the study for an incidence of 0.7 per 100 person years. So this figure shows PrEP adherence by electronic monitoring, that is Wisepill, and pharmacy refill, those who came back to the pharmacy in the 2 randomization arms. So the y-axis is the PrEP adherence data, the x-axis, the months of follow-up of 24 months, and the solid lines represent those who are randomized to SMS reminders, and the broken lines were those who were randomized to non-SMS reminders. So adherence data was averaged at each study visit for participants who had collected PrEP for the previous study period. So as you can see from this graph, just please go back a bit. Thank you. As you can see from this graph, there was no difference in adherence between those who were randomized to SMS reminders versus those who were not randomized to SMS reminders. And this was irrespective of whichever way you looked at it, whether adherence was by Wisepill or by pharmacy refill. Next. So SMS reminders did not improve PrEP adherence, and this we looked at both at 6 and 24 months. So electronic adherence monitoring was 40.2% with SMS reminders versus 36.8% for those who are not on SMS reminders. That was through 6 months. Over 24 months of follow-up, electronic monitoring adherence was 27% with SMS reminders versus 26.6% without SMS reminders, and there was no statistically significant differences that were seen. In addition, there were no significant differences on the effect of SMS reminders on adherence, regardless of refills or by study site. So this graph shows the correlation between electronically monitored adherence and tenofovir diphosphate concentrations from the dried blood spots. The y-axis represents tenofovir diphosphate concentrations from the DBS, the x-axis openings of the Wisepill device. And we can see that people who open the Wisepill device more frequently had higher tenofovir levels in their DBS. So there was probably a moderately high association with electronically monitored adherence and tenofovir diphosphate concentrations on DBS with a rho of 0.59, giving us some confidence in the accuracy of the electronic adherence monitoring. So in summary, our takeaway from the trial is that SMS reminders did not promote PrEP adherence among young Kenyan women. Secondly, alternate formulations that do not require daily dosing may be promising for those with adherence challenges. And for those desiring oral PrEP, additional adherence support for interventions are needed. So although SMS did not help in our study, novel uses of technology could be considered to facilitate PrEP delivery. So I will hand over to our next presenter. Thank you.
Good afternoon, everyone. My name is Jessica Haber, and I'm pleased to present to you some of the factors that influence PrEP adherence in our study. Next slide. So as Catherine showed you, we had generally declining adherence over the course of the study. And in looking at it with the different measures, we can learn quite a bit about what actually happened with the day-to-day doses, which is a real benefit of the Wisepill device. And this information here is very similar to what you saw in the other figure, but we're breaking it down by the number of doses that were taken on average per week. So you can see in each of the bars, going from the early beginnings of the study through to the end of 24 months, each bar represents a 3-month period. The red areas indicate when essentially no PrEP was taken or less than 1 dose per week on average. And the green areas indicate when PrEP was taken on a very consistent basis at 6 or more doses per week. And our goal in achieving HIV prevention is really best obtained through high and consistent dosing of PrEP, which would be in those green areas. So by understanding how many doses are being taken per week, we can get a sense as to whether there was consistent protection or perhaps intermittent dosing. And that's essentially what we saw with adherence dropping off fairly rapidly, but there were continued dosing events periodically throughout the follow-up period. Next slide. We looked at a number of socio-behavioral factors to try and understand what influenced adherence, such that some women were able to achieve high consistent adherence, others didn't take it very much at all, and there were some who were in between. And I'm not going to go through all of the different factors that you see here, but just want to let you know that we looked at individual factors that may have been related to demographics, certain types of behaviors like alcohol use, as well as how the women felt about themselves and their relationships, and also their perceived need and concerns about taking PrEP. We also looked at partnership factors to understand how that may influence adherence, such as the amount of sex they were having, who they were having sex with, and what their relationships were like. We also looked at other factors such as what's going on in the community, which can have a significant impact on a woman's ability to take PrEP, as well as structural factors such as how easy was it for her to get to clinic. Next slide, please. Just go back one, thank you. So we looked at these factors in multivariable models to try and understand how they all work together and what may have had an impact on adherence. And we chose to look at a level of effective adherence, so 5 or more doses per week on average, according to the Wisepill device. We also looked at these factors at higher levels, which we know are more likely to protect, but we feel that 5 out of 7 doses per week is a reasonable benchmark to understand if effective adherence was achieved. And in looking at all those different factors, we learned that 4 had a particular impact on the ability to achieve high adherence. Specifically, the lower the voice risk score, the higher the adherence. That may seem a little bit counterintuitive, but I think it speaks to the difficulty that some women have in having control over potential risk for HIV, and as well their ability to take preventative medicine. The more sexual partners a woman had, the more likely she was to be adherent, which I think also speaks to the ability to recognize ongoing risk. And we'll talk more about that in a few minutes with our qualitative work. There was a difference by site. The impact of our intervention did not differ by site, but the ability to adhere was higher in the consumer site. And women who had to travel less than an hour did better in terms of achieving high adherence. We did see potential effects that might be more significant in a larger sample, including more sexual relationship power, perceived low HIV stigma, not being depressed, and having less concern about taking PrEP. So these are factors to consider moving forward. Next slide, please. As Dr. Prakusi mentioned, we also did collect data on risk through weekly surveys to try and understand how that behavior and those perceptions might change during the course of the study. And the surveys were quite successful. We were able to send 84% of them as planned, and over 3/4 were answered by the vast majority of our participants. And in these surveys, we asked about sexual activity, excuse me, whether condoms were used, if they thought their partner might have HIV, what their general perceived risk was, and if they perceived that they were protected by PrEP. And although we did get very good responses, we unfortunately did not see an impact on adherence based on these responses. Next slide. So for this portion of the talk, let me hand this over to Dr. Nguri, who led our qualitative work in the study.
Thank you, Dr. Jessica. Greetings, everyone. I hope you're doing well. I'll share with you what you've learned from the qualitative interviews, and specifically around HIV risk. And as Professor Bukusi mentioned earlier, is that we conducted serial interviews at 3 time points, at closer to enrollment, at month 6, and at month 12. And the reason why we do qualitative work is to learn the hows and the whys. And specifically what we learned from the qualitative work is that the young women enrolled in our study perceived themselves at risk of HIV acquisition. This was based on their dynamic sexual behaviors and their evolving relationships. But also more importantly, we learned that the HIV risk perception was dynamic, it's not static. So young women's risk changed, and this also influenced their PrEP use, starts and stops, and condom use over time. So a take-home message from this is when targeting young women who are already aware of their HIV risk could increase uptake. And therefore, there is a need to use innovative strategies to educate women on their risk, which could translate into higher uptake and continuation of PrEP. Next. This risk was able to fit in very well with a model that many of us are familiar with, which is the expanded health belief model, and which has several components. And I will not go through these specific components, but I'll tell you a story of Anne. And of course, that's not her true name. Anne is a young woman aged 19 years, comes to the facility because she feels at risk. She has a new partner. The partner often refuses to use condoms and has refused to test. So she thinks that this partner could be HIV infected. She actually thinks that's the reason why the partner is refusing to test. When she comes to the clinic, she is able to undergo HIV counseling, and she is educated on PrEP. And she is in the facility, she finds very friendly counselors. She is able to ask questions regarding PrEP adherence. And based on that communication, she is able to initiate PrEP. But during the subsequent visits, she is counseled and capacity built to be able to convince her partner to come for HIV testing. She's able to bring her partner on the month 6 visit, and they are tested together for a couple HIV testing. And what she learns is that her partner is negative. So she then stops taking PrEP because she feels that her partner is not HIV positive as she thought. And this Anne's story is only one of the many stories that we learned about how people would change their behaviors during follow-up because of being in a program that provided PrEP, counseling, and additional support. So next. I'll now hand over to Dr. Jessica to conclude for this session.
Thanks so much, Dr. Nguri. And I think the mixed methods that we use in the study were really informative to understand these factors. And so in some, as you could see from the slides I presented and those that Catherine presented, PrEP adherence was modest and it did decline over time. We saw very complex relationships between HIV risk and adherence. And I think the qualitative work again speaks to the dynamic nature of risk and when women may need to be taking PrEP. Having a simple metric of multiple concurrent sexual partners may offer a promising approach for increasing adherence among women who are interested in taking PrEP, especially given the complexities that we saw around understanding risk. Some more practical issues like ease of clinic access and certain site level factors may also be quite relevant, suggesting that the way we deliver PrEP is really important, and having a low burden, user-friendly delivery platform is very important. The relatively low incidence that we saw in this study suggests that partners may have achieved protection through multiple strategies. As Dr. Bukusi mentioned at the beginning, we were actually expecting around 5 per 100 person years in terms of infections. It was actually much lower than that at 1.25. So there's a lot to understand here, knowing that PrEP plays a big role in HIV prevention, but so do the programs and that dynamic relationship with risk and the counseling that Dr. Nguri described. And I think at the end of the day, having long-acting formulations for those who are struggling with adherence or, excuse me, or their risk assessment may make PrEP a lot easier for women, but certainly we need to consider how to support them for oral PrEP if that's their chosen formulation. And with that, we'll go on to the next slide, and I'll turn this over to Kevin Komolo.
Thank you so much, Dr. Jessica. I will now take the team through the reasons for declining PrEP. We had a number of participants, the potential participants, who are all approached to take part in the study, but at the end of the day, they did not participate. So we conducted a qualitative study, which was a two-phase qualitative study using semi-structured guides. We conducted a total of 40 in-depth interviews, 20 in Kisumu and 20 in Thika site. And here we were assessing the concerns about PrEP and study participation. What is it that made these participants not to participate in the study? Also, focus group discussions were done, and a total of 10 were conducted, 5 in Kisumu and 5 in Thika, of which we did include the peers, young men, caregivers, and community leaders. Here we were exploring the community level factors which influence PrEP decision making. And for this qualitative study, triadic influence theory guided the whole study. Next. On results, a total of 28% of young women who qualified for MPYA chose not to enroll in the trial. And further, we seek to know what were some of these reasons, the barriers that deterred them from participating. And they were categorized into 4. We had the individual, social, structural, and support barriers. And what was coming out was that there was the risk perception, self-efficacy, whereby some self-assessed themselves and they were of the opinion that they could not use PrEP. There was the misperceptions of PrEP usage, the misperceptions of side effects, concerns of addictions, perceived and enacted stigma, mistrust in partnerships. There were competing needs. Some did mention that instead of participating in a study whereby they'll be taking PrEP, they were busy at workplaces, some were busy at school. There were monetary constraints, and religious influences were also some of the reasons that were mentioned. Not to forget perceptions of personal responsibility. Next. Now, the takeaways from PrEP decliners sub-study. Number 1, navigating barriers, preventing PrEP initiation is complex, especially in settings where it may be perceived as an immoral behavior. Secondly, campaigns on need for PrEP should be done within the context of risk perception to avoid potential risk of losing community support. And finally, for future directions, there is a potential need to address social norms while demedicalizing HIV prevention services. I now hand it over to the next presenter. Thank you.
Greetings again. So I'm making this presentation on behalf of Nicholas Thuo, who had made this presentation on Alpha-P 2018. And this is on the factors influencing PrEP uptake. Next. And specifically, we conducted qualitative interviews with 50 adolescent girls and young women. And what we learned, what was different from the women who enrolled into this trial versus those who declined. And Kamoro has told us about the 28% or 179 young women who declined, is that these ones who accepted enrolled in this trial so that they could take PrEP for fear or concerns about HIV acquisition, and partly because of their own behaviors, for example, being in multiple relationships. But the other reason is that for fear of HIV acquisition, specifically because they thought of HIV as a deadly disease. It was actually surprising for us to hear, even in this era of ALT, that the young women considered HIV a deadly disease. With some, I remember a specific quote where even the young women said that even with ALT, it's only prolonging your death. Your death will be coming soon. I think that that calls for an opportunity to continue educating on benefits of ALT. The other reason that made these young women take up PrEP was the perceptions of partners' HIV status. One, either they were unaware of their partner's status, or they were unable to convince them, or they even wrongly assumed that they were HIV positive. And we were able to see several cases of those where someone reported they were in different or discordant relationships, but once they brought their partner, the partner ended up testing negative. The other one was the issue of alcohol use, and especially when they took alcohol, they reported that they were unable to make good decisions, and that is why they chose better for them to initiate PrEP. The other reason that made these women initiate PrEP was inconsistency or absence of condom use, and especially the young women reported that they were unable to negotiate condom use or had challenges in negotiating condom use, especially in transactional relationships. Next. So, and from this is that we were able to learn, or the take-home message is that fear of HIV acquisition coupled with self-evaluation of being at risk may increase their PrEP uptake, and there is therefore a need for PrEP education and to use peers to increase demand of PrEP among young women. Next. That's also again me. I'll talk about another interesting study, or one of my favorite also components of this study is on PrEP formulation preferences. So after we had these young women for 2 years, we administered an exit survey among about 150 of them, and we asked them if other formulations were available for PrEP. For example, the vaginal ring, which you know is in the pipeline, the injectables, the implants were available, which method would they choose? And remember, these were young women who had experienced oral PrEP. Surprisingly, and although not very surprising, especially if you are familiar with the contraceptive field, is that the injectable was ranked first by about 36% of them, closely followed by the oral methods by about 34% of them. And then lastly, the one that received the least ranking as being a first method was event. So that is very well known in Kenya, because we were able to equate, the young women in our study were able to equate these methods with, for example, the injectable, Depo-Provera, the implants, no plants, but they didn't have, Nuvaring is not very well known in Kenya, probably. That's why it was not ranked first. And but then when we followed this question with a different question about wanting to learn more about the methods, they also reported that many of them reported that they would want to learn about the vaginal ring. So next. So the takeaway message from this is that for women, despite being on oral PrEP for 2 years, only a third of the women would prefer oral formulations if other formulations were available. And this would, for example, be able to explain why we observed suboptimal adherence with about close to a third being adherent, possibly because they would have preferred other methods. And you know the reasons why people prefer other methods, like Depo-Provera, we know that this doesn't require daily adherence. It can be used discreetly. So that's one of the key reasons. So our findings demonstrate that both systemic and local acting products would have a space in the prevention arena, similar to the experience that has been seen in the contraception field, where in addition to oral contraception, other methods such as injectables, implants, and vaginal rings are also preferred by women. So meaning that there's need to offer choice. Next. I'll now pass over to the next presenter.
Thank you, Prof. Ngure. I want to present on behalf of the team and the investigators on the acceptability and feasibility of Wisepill device. This is part of the work that we presented in the last Association of Physicians and AIDS Care conference in 2020 on acceptability and feasibility of Wisepill device. I'm Eric Seda. Basically, a real-time monitoring can be highly useful for understanding adherence behavior, but may not be acceptable and or feasible in all settings. In this sub-study, we sought to understand the experiences of using real-time adherence monitor for PrEP delivery among young Kenyan women. How did we do this? We assessed acceptability quantitatively according to the unified theory of acceptance and use of technology. And all the responses were recorded with Likert scales. Feasibility was assessed by daily Wisepill functionality. And that is monitoring of the device heartbeat, meaning we were monitoring every opening of the Wisepill device remotely and recorded this in our dashboard at the clinic during this period of the PrEP use. Next slide. Now, what did we find out? Majority of young women perceived Wisepill to be very useful, although a few of them, as you can see in this slide, had a lot of problems and perceived Wisepill to be very complicated. Still on perception, we found out that a recognizable number of participants were worried about where to store the Wisepill device. It is significant to note that majority of these participants had interest on the Wisepill device. It is also important to note that the primary challenges were participants not following up and or bringing the devices to swap or charge the battery. Next slide. Now on Wisepill and cost versus SMS, we found out that Wisepill monitoring with SMS reminders had an incremental cost of about 1,293 Kenya shillings per month of the intervention coverage. And we project that at scale, the incremental cost would be Kenya shillings 774. And we know that PrEP costs about 700 Kenya shillings per month. Now you can figure out on how this Wisepill device can be scaled in the general population. SMS reminders also had an incremental cost of Kenya shillings 786 at program volume. And we also project that at scale, this incremental cost would be Kenya shillings 282. This is very much and very, very significant finding. The vast majority of the cost was driven by supplies, that is the capital goods, overhead, training, and personnel. And when you look at these two interventions, they added 2 minutes to each clinical encounter. Now, what did we learn? Young women taking PrEP in Kenya have great interest and high perceptions in real-time monitoring of adherence. The main challenge for feasibility lay in participant engagement with PrEP delivery rather than the functionality. We highly recommend that future studies should consider real-time monitoring to understand PrEP adherence among young women. And SMS reminders are more affordable than Wisepill, but still, we advise that Wisepill can still be used for research purposes. I'm taking it back to Jessica.
Great, thank you so much, Eric. Those were all excellent presentations, and I'd like to just finish by going over some of the main findings of each of the presentations you've heard today. I know we've talked about a lot in this study, and there's even more that we haven't presented today, just for sake of time. But I think from a high level, we can understand in this study of PrEP use over 2 years that unfortunately SMS reminders did not improve PrEP adherence as we had hoped they would. There certainly has been a lot of interest in SMS reminders over the years, and I think they have been quite helpful in a number of ways, particularly around reminders for appointments. But one of our concerns is that the SMS is now so much a part of daily life that the impact of that intervention is not as strong as perhaps it once was or potentially could be. Although, as we mentioned before, there may still be use for technology and helping to figure out better ways to deliver PrEP. I think the overall interest in PrEP was quite high. This was a cohort of women who were very interested in taking PrEP and recognized for the most part that they could have benefit from PrEP, at least at the beginning of the study. But adherence was quite modest and declined quickly over time. We found that few participants had levels of PrEP adherence likely to provide protection against HIV. But as I mentioned, the actual incidence was lower than what we had anticipated. And that's suggesting perhaps that women were taking PrEP at the time that they needed it. This would be a much more targeted approach to taking PrEP, that concept of prevention effective adherence that we described. And as you saw in that very colorful figure I presented, there was sporadic use of PrEP. So that is possible. That being said, PrEP doesn't work necessarily on a day-to-day basis. You do need to take it for some period of time before exposure and potentially after exposure to achieve protection. So our alternate hypothesis is that there were changing risk behaviors and risk perception over the course of the study, as Dr. Nguri described with our qualitative work. And I think that really speaks to the potential for all types of HIV prevention programs to really have an impact in this population. And I think PrEP is a very key component of that, but I think we need to look more broadly at how PrEP fits into all of the other options that women have for HIV prevention. And it's, I think the power of PrEP may perhaps lie in its known efficacy and its ability to catalyze self-empowerment among women. As Nguri also presented, new PrEP formulation choice will be very important going forward. And I'm excited to see all of the long-acting medications that are being advanced through the research process, either through injection or just longer-acting pills, or perhaps the ring and other formulations in the future. As we heard from Kevin, the lack of interest in PrEP among some women was really driven by stigma and morality. And I think there's a lot of work to be done about making PrEP more normal and acceptable in general society. And then finally, this study also did look at technology in a lot of ways, the SMS reminders, but also the Wisepill device to understand how it could be used for research, as well as potentially clinical practice. But I think we saw that at this point, it is still quite costly, although there are lower cost versions now of this device that could be considered going forward. Next slide, please. So I'd like to conclude our formal presentation with acknowledgements and many thanks to our study participants, the research teams in both Kisumu and Thika. We had very active and involved community advisory boards, and of course our funders at the NIH and the National Institute of Mental Health. And if I could ask Lindsay to go back to I think it's the third slide, we have a list of all of the members of our team that I think we went over a little quickly, but this was the work of many, many people, as you can see in the photos here. And I just want to acknowledge their contributions because the study by no means could have happened without them. And here you can see one additional principal investigator, Dr. Jared Baton, who was unfortunately not available to join us today, as well as a few other investigators. And again, a big team of people who helped with participant recruitment, data collection, evaluation, study management, and of course, the many analyses that we presented here today. And with that, I will conclude our formal presentation, and I'll give the floor to Dr. Nellie Mugo, who is also one of our principal investigators, and just give her a moment to make a few comments about the study, and then we'll open it up for questions. Dr. Mugo?
Good afternoon. Apologies for my on and off. My internet has been iffy. This was a really interesting and an engaging study to participate in. And I think one of the things that continuously surprised me is that in spite of that low adherence, that the prevention rates were really high. And it's just a reminder that engaging young women in prevention strategies is in itself, but also that say text messaging will work. It should improve our adherence. Girls just need to be reminded. But until we put it through the rigors of research, it's likely that we would move on into program to implement something that's fairly expensive, and we wouldn't be able to evaluate whether it has an added value or not. But I think this information, this knowledge that we have now opens other pathways to really continue to seek for further understanding of the things that drive young women to initiate PrEP and retain PrEP. And I think one of the other really important findings is the issues around self-efficacy, that the girls who had no problems, didn't feel social stigma about taking PrEP, were able to adhere. The girls who recognized their risk were able to adhere. And on the other qualitative stigma issues. So I think in programming, what I would say is that perhaps we do need to put resources into reducing social stigma towards PrEP, or perhaps towards women's sexuality and the issues around improving girl empowerment. That's a very long version of my take back, but this was an extremely engaging and interesting cohort. I'd like to really thank Jessica Habaro, who brought up this protocol to us. Both the Kisumu teams, Professor Elizabeth Bukusi's team, and our team, led really by Kenneth Ngure in Thika, for the quality of work, and our colleagues at the University of Washington, and also NAC for this opportunity to make these presentations. I was looking for comments on the chat, so I don't know whether we should see if anybody wants to verbalize any additional comments.
Thanks so much, Dr. Mugo. I've been monitoring the Q&A, and the first question that came up is, did the risk perception perhaps decline over time, explaining the decline in adherence observed? Would you like to comment on that? And then we can perhaps get further input from Dr. Nguri with the qualitative work.
Yes, I can comment.
Please.
Yes, being enrolled in a clinical trial, as we said, PrEP was provided as part of a comprehensive prevention package that included counseling, condoms, etc. And during follow-up, the women were counseled on ways, for example, to be able to bring their partners for testing. So when they tested their partners and were able to see that they were negative, then that's one group. They were able then to have a lower risk perception. Others were able to gain ability to negotiate condom use. Others, just by regular testing and meeting counselors, were able to modify their behaviors. Others reported they got married. So we have different stories that align to this thought of reducing risk during follow-up. And it's a benefit of also being in a cohort.
I saw a question about commenting about the pivirine ring uptake in Kenya. I don't think we have disseminated it yet, unless somebody can tell me otherwise. I think the plans are in place now that we have WHO approval. But I suspect you cannot find it if you go looking for it in facilities. I also wondered if Murugi Misheni had any additional comments, because she was also part of this protocol investigating team and did some additional work on this data.
Thank you, Dr. Mugo. I was just sitting here thinking that what was presented, especially by Professor Ngure and Dr. Jessica, mirrored closely what I found when I was looking at my, when I was doing my thesis work, especially regarding the dynamic nature of risk, looking at partner involvement, looking at and as you mentioned, self-efficacy. These were issues that also came out clearly when we triangulated the qualitative and the quantitative data. And I'd be happy to share more about this at another time, but I don't want to do that now because I'd want to give those who have presented more time to answer questions. And one that I think continues to be asked is, well, let me start with the one that I had. Professor Ngure, you did talk about that from the qualitative findings, targeting young women at high risk of HIV was one of the approaches. So the question I would have is, are we comfortable to say that we can identify high-risk women, and how would we go around doing that, or being able to reach them and make them, or engage them in self-awareness of risk? Because I think that's where the issue has been for a while. Thank you.
May I go ahead? So yes, so I think you bring in a very important question, Dr. Murugi. The issue of risk perception is that we found that about 179 women did not enroll because they did not perceive themselves at risk. But truly, if you ran a risk score, they would probably score higher. So there's still a significant proportion of women who may not perceive themselves at risk, and so they are not aware that they are at risk, and so probably they even continue engaging in whatever risky behaviors that they may be engaging. So there's actually a need to look for innovative ways to educate young women on their risk, so that they are aware and they are able to take up interventions that would reduce this risk, whether it's biomedical interventions, whether it is our old ABCs. Because if you look in our demographics, and especially in some of the regions in Kenya, you will see that addressing girls and young women are among the highest risk groups. The reason being partly because of risk perception, then they are able to sort of to continue engaging in risky behavior. So probably that would be my answer.
Thank you, Prof. I'd also want to ask to read out loud a question that is in the Q&A. How can condom use be encouraged? Because from the presentation, prevention has focused on HIV and not other STIs. I won't direct that to one person in particular. I'd leave it open to the panelists.
I wonder if Professor Bukusi could actually tackle that, because I think it's a subject I've heard her speak to.
That's being thrown into the deep end. It's a difficult question, because just as Professor Ngure has said, in order for people to use a preventive mechanism appropriately, they need to know that they're at risk or feel they're at risk, and then they can make choices. The challenging thing, however, is that when people do not perceive themselves at risk, then it's very hard for them to make that choice or take action. And I think as has been alluded to earlier, one of the things is when someone accesses prevention options, they may feel, or they themselves sometimes judge themselves thinking, am I making a decision about wanting to have sex or going to have sex? Is it right? Is it not right? And so I think that place of self-awareness, of making choices, about what someone does want to do or does not want to do, and then taking appropriate decisions about protecting themselves is very important. Now, how do we get to that point? I think we really need to continue to raise awareness and empower both young men and young women to make choices about what they want to do, how they want to do it, and then make it possible for them to have access to the prevention options that would make sense for them. Sex often happens very sporadically and unplanned. And so if they're not in a relationship that is consistent, that is there, where they know they're going to have sex on certain days, then they need to have enough empowerment to be able to make choices and decisions a priori ahead of time to be able to protect themselves. So it's a difficult question. I probably haven't answered it as well. And maybe Dr. Mugo, you'd want to add something to this. But I think just giving people that space where they can be self-aware enough to be able to make choices, because not everything works for everybody all the time. Back to you, Dr. Mugo.
I think you've tackled it really well. I mean, my general view here is we had good uptake, and I think that's been seen across programs for PrEP, but low retention. We know that condom use is low, and there's also stigma around a girl proposing condom or using it, the same way we found that there's stigma around PrEP. So maybe those similarities of stigma are the ones which reduce the use of condoms. I've always wondered about the messaging. Maybe we need to review what message would resonate with young women that would allow them to take up condoms, maybe issues of fertility. Our lack of STI screening tools across facilities in our health services may also be undermining our ability to counsel and strengthen STI prevention. But as Professor Bukusi said, there's no one correct answer. I can see we are 3 minutes to time, so who shall I hand over to?
Maybe I can just pose a couple other questions that I've seen come through the Q&A. There was a question about the influence of men in this study. Someone like to comment on that? For uptake and for adherence as well.
Can't remember what was the population of married and not married. Can't really recall, but I know on site. Maybe Kenyan, you can mention it from the qualitative, perhaps. Yes. Because we didn't engage men directly.
Yes, I think men play a critical role for uptake and continuation of interventions. And that is why you see, even from not only in the HIV field, even in the contraceptive field, one of the reasons that women have given us for the preference or why the Depo-Provera is very popular is that it can be used discreetly. Something else I said earlier on is about the inconsistent condom use. The reason why young women are not probably able to negotiate or maintain consistent condom use were told from the qualitative interviews is that, for example, during transactional relationships, what they would call sponsor relationships, is that then they would not be able to convince the male partners to use condoms, or even in relationships that are not yet stable. So that is a key reason. So male partners are key when it comes to uptake and continuation. And probably as we continue doing some of these studies, it's always good to involve male partners so that they understand. We have been told many times of how they had challenges in hiding this Truvada or PrEP. Some of them have even reported some violence because they have been found with it and been told that you are on ART and you've not informed me. So those kind of things, male partners play a key role, and there is need to look for innovative ways to include men in these rollouts.
I think there might be a question from Omu Anzala. I see a hand perhaps being raised. There we go. Omu Anzala, would you like to go ahead and ask your question live? You are muted.
This is great. Let me congratulate all of you guys for this great work. I've been listening quietly because these are some of the challenges we all face, and I'm glad to see that really good information is coming out that can inform what to do and not what to do. Mine is just to worry a little bit about STIs. I know Nelly talked about that. I'd have really liked to see data on STIs. We are still struggling with gonorrhea and other things, so that could be a good addition, because if you can reach this age group, STIs are critical to know exactly what is circulating. Then number two is the issue that we are leaving out a large segment of people who are contributors to this problem, and that is men. So as we move ahead, social science has concentrated a lot on women and female, and it's really a high time we started thinking of how we can also include young men and as well as young men who are also contributors to this. And then thirdly, when I look at data in terms of prevention, what comes to mind is that you are measuring serum levels of the antiretroviral drug. My worry is maybe we should begin to think of looking at mucosal level, because you might find a decline at the peripheral level, but there could be a high retention of this drug at mucosal level. Maybe as we go ahead, this could actually be a way of also looking at the two. I say that because for us now, our concentration, even when we are looking at vaccines, we are now looking at both aspects. We are not just looking at peripheral side for elicitation of immune responses. We are really concentrating at the mucosal level. And that's where we really know that the protection and the exposure actually occurs. So I'd like to hear from you, Jessica, from Nelly, and from my good friends, Elizabeth, who have not seen post-COVID, to really talk about a little bit about this. But thank you so much for giving me the opportunity to give a call.
Thank you so much for those important questions. And I do recognize that we're at the top of the hour, but I would like to just comment briefly on your point about men. And I'd like to even expand that to the community, because I think we focused a lot on young women. They definitely need that focus, but they don't live in isolation. And I think just reflecting on who young women are, at this vulnerable time in their lives, they have a lot of neurocognitive development that's still ongoing. And I think we're asking a lot when we give different HIV prevention strategies that require ongoing behaviors and recognition of things they may not truly understand or prioritize, which is completely normal and typical and expected at that time in their lives. So enlisting the support of communities to make HIV prevention part of what is expected and what is normal, I think could go a long way. As Nguri was describing, men have a very critical role to play, both as advocates and potential barriers. And I think we do need to engage with them more to understand how we can optimize the ability of women to protect themselves. And finally, to think about those structural factors, how we deliver PrEP, how we make it easy for women to take, so that those other barriers don't have to be quite so high. I personally am not doing any work at the mucosa level. I do know there's a lot going on in that area, and I appreciate you raising that as well, because I think we do need to understand much more about the biology of HIV prevention. And then maybe I'll open up the floor for one more response, either from maybe Dr. Mugo or Dr. Bakusi to the questions posed, and then I think we'll probably need to conclude.
I think I've talked quite a bit. Prof. Edie, would you like to close us?
I think it's really just to say thank you very much to everyone and for making the time to come and listen to the work that we did and to share their thoughts and ask the questions. It's not the end. There's still a lot that needs to be done. I saw some interesting questions around the pivoting ring and other options. We still haven't cracked the code on this yet. We still have a lot that we need to understand and a lot that we need to do. And COVID isn't making it easier, just as Professor Anzala said, it's not making our lives any easier, but we can't quit. We still need to keep finding options and being able to help people live their lives as best as possible. So thank you very much. Maybe we can hand it over to Dr. Murugi to close out on behalf of NARC.
Thank you very much, everyone, for joining us and for the presentation. The work that has gone into getting this together and so flawlessly, it worked so well. Thank you. And also like to open up to the others who are joining us, that this is a forum that you could use to share and discuss your work. So if you'd like to do something similar, a webinar or a presentation through the NARC portals, please get in touch with me or through the research division. We'd be happy to host you and help you prepare for this. Thank you very much, everyone, and have a good evening.
Thank you. Bye.
Thank you. Bye.
Bye-bye.
Thank you, everyone.
Bye.
Bye.
Bye.